Welcome to another exciting discussion around resuscitation. My name is Dr. Benjamin Ashira. I'm an emergency physician, and today's topic is it's interesting. Probably not the common way we'd be discussing shock. So looking forward to your engagement. And as always, if you have any questions, feel free to put them in the chat, put them in the Q&A parts of it, and hopefully we'll take step by step to understanding shock. I think one of the things that definitely cause a lot of patients to deteriorate and to crash is shock, and early recognition of shock can actually save your patient's life. But the problem is we always delay in this recognition, and this is what causes all the issues. All right, so picking up from where we started off, okay? So the approach to the basic patient who is crashing is, do they have a pulse, yes or no? All right, if yes, then fine. If no, then we start CPR. Is there trauma, yes or no? That means do I need to maintain C-spine, or they have no trauma, then I just kind of go down the algorithm. Airway, is it open, maintainable? Do I need to intubate? Okay, so we captured a lot of this in the first series, so make sure you watch that. And then we discussed the airway and breathing parts of it. So breathing, what I'm looking at is what's the patient's rate of breathing, air entry, color, effort, saturations, okay? And then the mnemonic races captures that. And then circulation, we have rate, level of consciousness using ABPU, color, ACG, systolic blood pressure, and again, races is a mnemonic capturing that. So today we're on races. We've already talked about the other four parts of it in the previous two series, so make sure you catch that if you've not been following along. But today our main focus is on circulation and the shock patient. And then finally, then you have disability, which you're looking at the GCS, pupils, and the random blood sugar. So that's a baseline and basic approach to any resuscitation patient or any patient who's busy crashing. So this is just a crashing patient before you need to start CPR. Going through these 6 steps essentially helps you evaluate the patient effectively and make a plan for the patient. So a common hilarious comment I get from people is, my patient's blood pressure is normal. Like, what does that even mean? What is a normal blood pressure? So just have a say, let me start telling you a bit of a story about blood pressure. So then at the end of it, you can tell me what is a normal blood pressure. So let's go to the basics, okay? What is a blood pressure, all right? Mathematically, I use the formula. So blood pressure is cardiac output times systemic vascular resistance, okay? Cardiac output can be broken into a heart rate, stroke volume, systemic vascular, cardiac output is heart rate and stroke volume, okay? So whatever you see as your blood pressure on any monitor when you measure blood pressure is a factor of your patient's heart rate, your patient's stroke volume, patient systemic vascular resistance, okay? So that's the blood pressure formula, okay? So basics, physiology 101, okay? So how does this look like? If we were to look at it from the perspective of, I know, yes, fuel is a topical issue in this country. We're currently paying tons of money for fuel. So it's why I actually wanted to use that today, so that we actually understand the cost of blood pressure and resuscitation, and understanding which parts of the whole system work. So if you look at it, if you look at the body as your fuel station and you have your car, you being the car, your tissues are the organs of the car. So blood pressure is affected by the heart rate. So in this particular situation, the heart is the gas pump, the fuel pump. It can be an issue of volume, okay? Since in this situation, you're talking about blood volume, okay? And so that's your stroke volume. Or it can be the pipes, okay? Systemic vascular resistance, okay? So blood pressure, using the analogy of gas station or fuel station, the heart is where your heart rate is affected. Your vasculature is your systemic vascular resistance, and your blood volume is your stroke volume, okay? Good. So back to my BP, all right? So BP is heart rate times stroke volume times systemic vascular resistance. So let's play with some numbers, okay? This is math. Wale walala algebra, pole sana. We are back there, or whatever was it, algebra, all those funny equations I can barely remember. So let's put numbers to this thing. These are not real numbers. They do not really represent anything particular, but just simple mathematical formula. All right, let's say blood pressure is 120, okay? So let's give it a value of 120. That means, and we give heart rate a value of 15, stroke volume a value of 4, systemic vascular resistance, a value of 2. Okay, so 15 times 4 is 60. 60 times 2 is 120. And there's your blood pressure. Okay, simple mathematics. All right. So let's take a situation where we drop the heart rate. Okay, so the heart rate was 15. Okay, now, so these are not actual numbers. We're just dropping it. So drop the number to 5. Okay, what will your body do to compensate for this? Okay, so the first thing is you're going to vasoconstrict. Okay, so your systemic vascular resistance has gone up. Okay, these are not real numbers, just playing with the numbers. So the moment your heart rate drops, your body is like, okay, what's going on? What's going on? What's going on? So the first thing it's going to do is going to cause vasoconstriction. So systemic vascular resistance will go up. Okay, and then your stroke volume will more or less remain the same. Okay, because you're not bleeding, just your heart rate dropped. You increase the systemic vascular resistance, your stroke volume more or less remains the same. But let's look at that. So 5 times 4, 20. Okay, 20 times 6, 120. Okay, but at this point, so your blood pressure has been maintained. Okay, but you are not where you started off. Okay, you are here where everything was within normal, but now you have a lower heart rate and you're vasoconstricted. Okay, so this would be an example, for example, a patient who is becoming bradycardic, okay? This is normally maybe bradycardia secondary to response like hypoxia or something. So the heart rate will start dropping, or hypothermia, for example. Your patient who is hypothermic, the blood pressure will remain normal, but the heart rate will come down, okay? But to compensate for that, because we have to maintain it at 120, so your systemic vascular resistance will go up, okay? So they become vasoconstricted. There's no extra volume. You're a closed system, so there's no volume coming from anywhere, okay? All right, so good for that, okay? Now, let's take another example. Let's take you're running a tachy, okay? So SVT is a good example. Your heart rate is going up to 160, 165. Okay, what's your body gonna do initially? First thing, your stroke volume will come down, okay? Note, why is your stroke volume coming down yet you're not bleeding and you're not losing fluid, okay? So this is what's gonna happen. Because your heart rate is going too fast, then the amount of time it takes for your heart to fill up with blood is reduced, okay? So that means when your normal heart rate is at, let's say, 70 to 80 beats per minute, there's enough time for blood to fill, then it's pumped out, then it fills again. But if your heart rate is going almost close to 1.5 or 1.5 times its normal rate, then your heart there's no enough time for the heart to fill, okay? So the first thing that's going to happen is your stroke volume, the amount of blood being pumped outwards, is going to come down, okay? So how's your body going to deal with this? Because you're not just going to crash, okay? Your systemic vascular resistance is going to go up, okay? So let's look at this, the blood pressure. So 20 times 2 is 40 times 3, 120. So blood pressure maintained. So your heart rate has gone up. Your stroke volume has come down because your heart is not does not have enough time to fill up with blood. And your systemic vascular resistance, now you start vasoconstricting to maintain your 120 blood pressure, okay? So these are all your body's normal compensatory mechanisms, okay? And it'll take a while. So your blood pressure only starts dropping when these mechanisms have been exhausted, okay? So as you can see, there's a lot of things that will happen before your blood pressure actually starts dropping. So all these are just normal mechanisms that your body tries to maintain that pressure flow, okay? Let's take one more. This is easy. You're bleeding, okay? You're bleeding, diarrhea, vomiting. That means your volume has actually come down, okay? You've lost volume, okay? So what's your body gonna do, okay? First thing, tachycardia, okay? Why? Well, the volume has come down. There's less blood to be flowing around, so we need to move it quickly through the system. Heart rate goes up, okay? What's the body gonna do? It's gonna vasoconstrict, okay? Because now we need to move this blood. There's less volume for the blood to exist within the body. There's less volume of blood. So we need to reduce the size of the pipes so that the same volume is circulated within the body as fast as possible. And again, your blood pressure still remains normal. So 20 times 2 is 40, 40 times 3 is 120. Okay. So essentially, all this is looking at all your normal compensatory mechanisms for any situation where there's an effect on your heart rate, there's an effect on your stroke volume, there's an effect in your systemic vascular resistance. So for example, let's drop your systemic vascular resistance, okay? So this happens in a patient, for example, in anaphylaxis, in septic shock, or neurogenic shock, where your blood vessels just become big and far. Okay. So your vascular resistance drops. Okay. So what's your body gonna do? Okay. First thing, of course, because of that massive, so your pipes are like this small and then now they're this big. So that means whatever blood is in there is now in a bigger volume. Okay. So your stroke volume is gonna come down. Okay. So your first thing is, so you're not bleeding, you're not losing fluid from anywhere, apart from maybe where you're leaking, maybe sepsis or anaphylaxis. But in neurogenic shock, for example, you're not leaking fluid. It's just that where your fluid exists, the tank has become bigger because your pipes have become bigger. Okay, so then what is your body gonna do? Increase the heart rate. So that way, 40 times 3, 120 times 1, 120. Your BP is maintained. Okay, so at any given point, your body is trying to keep up with to maintain these pressures, your blood pressure, so that if you find a patient, for example, with a BP of, let's say, 120, okay, it's not 120, 60, 120, 80, okay? So that blood pressure is not, what I'd say, is not a normal blood pressure if you've not factored in your heart rate, your stroke volume, your systemic vascular resistance, because what you're seeing is the end product of this heart rate times stroke volume times systemic vascular resistance. And so this patient, for example, is in trouble because they cannot vasoconstrict. Okay. Yes, the numbers look fine, but the heart rate, which is probably now at 120, is not a good thing. So when the nurse or someone is telling you, oh, my patient's blood pressure is 120/80. Oh, wait, but the heart rate is at 150. That's a patient in shock. Okay. So that patient the blood pressure is not normal. And that's why when someone tells you my patient has a normal blood pressure, you're like, no. Your patient's blood pressure is 120/80. What's their heart rate? Okay. And how are they perfusing? Okay. So you have to factor each of these components, not just the end product, because from all the examples we've seen here, the BP has not changed in any of these patients. BP has not changed in any of these patients, but your heart rate has changed, your stroke volume has changed, your systemic vascular has changed, but your blood pressure has maintained the same. Okay. So that's looking just at the blood pressure in a patient and saying, oh, my patient is fine, is a big mistake, because you will not, it's only after all these compensatory mechanisms have failed or have been exhausted mostly is when your blood pressure starts coming down. Okay, so now at least we know patients can only have shock when their blood pressure is low, right? So we've established, fine. BP will remain the same, all these other things could change, but we only say a patient is in shock when that blood pressure drops, okay? So let's see about that. No, let me just tell you another story, okay? Now, is shock equals to low BP? No. Let's look at the definition of shock, okay? Shock is a state of acute circulatory failure leading to decreased delivery of oxygenated blood. Okay, I've highlighted those words: decreased delivery of oxygenated blood to the body's organs or tissues, or impaired oxygen utilization by peripheral tissues, resulting in end organ dysfunction. Okay, so there are multiple factors here. So we pick each individually to try and figure this out and what actually happens. So let's pick the first one: decreased delivery of oxygenated blood. Okay, all right, so resulting in end organ dysfunction. Okay, so this is about delivery. Blood is delivered by all this. So blood here, we're talking about the fuel in our system here. So blood can fail to be delivered because the heart is not pumping adequately. That's one problem. Blood can fail to be delivered because the blood vessels so the heart it's either pumping too fast, too slow, it's not pumping hard enough. The blood vessels can be blocked, okay, like a pulmonary embolus, a heart attack, or the blood vessels can just be just expand, okay, like in anaphylaxis where there's no vasoconstriction happening, your blood vessel just vasodilated, okay. But there can also decrease delivery of blood because, well, you're bleeding or you have volume loss. Volume loss can be fluid loss from dehydration, sweating, whatever reason why you've lost volume. Okay, so when you say volume loss, we mean either you're using blood or you're using fluid from your body. Okay, from the different reasons. But I think the other thing that people fail to recognize is delivery of oxygenated blood. Okay, so that's a key thing to remember, because remember, resulting in end organ dysfunction. So the blood has to be oxygenated. So a patient who is not losing blood at all, but is hypoxic, can go into shock because remember, the end product you're looking at is any state that results in end organ dysfunction. Okay, so your patient can be in shock purely because, yes, the blood is being delivered, but the blood has no oxygen. Okay, so essentially, your tissues are ending up in end organ dysfunction, and that patient can end up again in shock. Remember, shock is not a low blood pressure. So I think that's one of the things that we really need to demystify is shock is not a low blood pressure. And I'll conclude when I go through all this. All right, let's go to the other part of it. Impaired oxygen utilization by peripheral tissues resulting in end organ dysfunction. So at this particular point, the problem is in the car, okay? Your heart is pumping fine, your blood vessels are working perfectly well. Hey, you even have blood, okay? And it's even got oxygen, okay? But your tissues are not working. Your tissues are not able to use that oxygen being delivered to it, resulting in end organ dysfunction, okay? So, and this is situations, for example, carbon monoxide poisoning or cyanide poisoning, or even in sepsis, for example, where your tissues are not able to utilize the oxygen being delivered to it adequately. That's your patient ends up in shock. So again, shock is not blood pressure. It's decreased delivery of oxygenated blood or impaired oxygen utilization by peripheral tissues, resulting in end organ dysfunction. So what is shock? So in summary, so what is shock? Okay. So shock is that situation where anything that will lead to end organ dysfunction. Okay. Any particular reason, whether it's blood is not being delivered, blood is not being delivered adequately, blood is being delivered, but it's not oxygenated, your tissues are not able to use the oxygen being delivered. So any of these situations that is leading to end organ dysfunction is shock. Okay. All right, I see there's a question. So how do adults compensate? How do adults compensate that is different from children in terms of stroke volume, systemic vascular resistance, and heart rate? Everyone compensates the same way, okay? So kids, for example, have a baseline faster heart rate, okay? So the level of compensation is already quite good, but they have less volume, okay? So a bleeding in a child will crash faster than a bleeding adult, for example, because their volume is much less. They have a higher heart rate because their volume is low, okay? But on a vascular resistance, both of them are actually probably doing the same thing in terms of vascular resistance. All right. Good. Any other questions? Feel free to put in the chat or put in the Q&A. All right. So I hope we are all together now that shock is any situation leading to end organ dysfunction. Okay. So, and this is end organ dysfunction because there's just blood flow problems, oxygen delivery problems, oxygen utilization problems. Okay. If you do not have any end organ dysfunction, ain't no shock. Okay. You do not have shock. Okay. If whatever is happening in your body is not ending up in end organ dysfunction, then you probably are not having shock, and you should be dealing with all other problems that is causing your patients to crash. Okay. All right. So let's look at others. So remember, shock can be because of decreased delivery of oxygen blood flow, okay, leading to end organ dysfunction, or decreased utilization of oxygen by the tissues, leading to end organ dysfunction. Okay. So how then do you start telling your patient is in shock? Okay. So again, shock is not blood pressure. Okay. So when we start knowing our patient is in shock, okay, so they're what we call markers of hypoperfusion, like markers of poor perfusion. And we have two of them. We have mean arterial pressures and the shock index. And I'm going to discuss this so that people understand. So note, blood pressure is not a marker of poor perfusion. Blood pressure is just a composite of your cardiac output, stroke volume, and systemic vascular resistance. It doesn't tell you about perfusion. What you're worried about is your patient perfusing? Is your patient perfusing with oxygen? Is your patient using the oxygen that that is getting to them? Okay. So mean arterial pressure essentially is a third the pulse pressure. Pulse pressure is systolic blood pressure minus diastolic blood pressure. And then you get your mean arterial pressure, which is what you're seeing over there. So the mean arterial pressure is that constant blood pressure or constant pressure within the tissues that the blood that doesn't really vary, because systolic blood pressure pretty much pushes the pressures up. Then pressures come down to your diastolic pressure, then back again up. So there's that constant pressure which is maintained, and that's what we call mean arterial pressure. And most machines, most devices, commercial devices or electronic blood pressure monitoring devices, like cardiac monitors, will tell you what the mean arterial pressure is. Okay, so what is a good, but you can also calculate it. As I said, it's a third. Pulse pressure is systolic blood pressure minus diastolic blood pressure. That difference divided by 3, you get your mean arterial pressure. So this is a good graph just showing you the importance of MAP. Okay, so this is a study that looked at patient survival for patients who had low MAPs. Okay, evidence of hypoperfusion. So the thinner line is MAP that was not maintained more than 65 within 12 hours. And as you can see, in terms of days of 0 to 90, essentially more or less like 100% mortality within the first day or so. Okay, so if you're not able to get your MAPs above 65, your patient's gonna die. Okay, they're gonna die sooner rather within 12 hours or so. If you see a mortality, so that's MAP is one of the key things that we always use in the emergency department to figure out our perfusion, our patient perfusion. As you can see, if a MAP is maintained above 65 within 12 hours, then they have a less mortality, and even at 90-day mortality is more or less around 50%. Okay, but for patients whose MAP is not maintained above 65, then within the first day or so, the mortality is almost 100%. Okay, so something to remember. Okay, now many people have not heard about shock index. Okay, shock index is something that's come into play in the last many years, well, a couple of years, and because blood pressure is such an unreliable marker of perfusion, because it just tells us end product numbers, they've looked at what else can we use, and because also blood pressure is affected by your patient's heart rate, it's affected by your patient's stroke volume, is affected by your patient's systemic vascular resistance. Then studies have looked at and come up with a shock index. So a shock index is your patient's heart rate divided by your systolic blood pressure. Okay, so if your heart rate is high and your blood pressure is low, which is probably you're already in shock at that point, then your systolic blood shock index is going to be high. Okay, so if your numerator exceeds significantly your denominator, this is again back to fractions now. If your systolic, if your numerator, which is your heart rate, exceeds your diastolic, your denominator, which is the systolic blood pressure, significantly, then your shock index will be above 1. Okay, now a normal shock index, your blood pressure should not be higher than your heart rate. Okay, your blood pressure should be more or less 70% of your heart rate. No, sorry, your heart rate should be 70% of your, am I doing the math right? Yes, of your systolic blood pressure. So a normal shock index is less than 0.7. A shock index more than 1, okay, essentially is a very specific predictor of a 28-day mortality. Okay, so if your patient comes in, you've taken their, for example, you've taken their blood pressure, it's a systolic of 110. Okay, systolic of 110, but they're running a heart rate of let's say 120 actually. Yes, 120 divided by 110 is definitely above 1. Your patient is in shock. The blood pressure is at 90. Okay. Sorry, the blood pressure is at 110 systolic, okay, which people would normally say, well, that's not shock. No. They're actually in shock, and they actually have a higher, they have a very high probability of dying within the next 28 days. That's a 28-day mortality. Okay, and they've looked at it from different perspectives. This is a table that compared all the studies looking at the shock index and its utility. You can see in a patient, for example, at triage, okay, and that's why patients coming in must be triaged. You need to get the vital signs from the word go to be able to categorize your patient into the different levels of severity and be able to then intervene accordingly. As you can see, shock index is better at predicting inpatient mortality than systolic blood pressure. Okay, doesn't affect ICU admission, doesn't predict ICU admission, but it has poor sensitivity in terms of predicting mortality, but inpatient overall mortality. But in terms of predicting inpatient mortality, shock index definitely above 0.7 is something that we predict inpatient mortality. Okay, though, yes. If you're looking at a trauma patient, for example, so shock index more than 0.9 correlates with an increased need for massive transfusion. Okay, again, always looking at that. Shock index more than 1 performs similarly to a systolic blood pressure less than 90. If you look at it from an obstetrics and a ruptured ectopic pregnancy perspective, shock index consistently is higher in ruptured ectopic pregnancy compared to an ruptured ectopic pregnancy. Okay, shock index more than 7 was more sensitive. Okay, more than 0.85 was more specific. So in any situation where your patient's shock index, so your heart rate divided by systolic blood pressure is above 0.7, you're in trouble. Okay, so your systolic blood pressure could easily be reading 120. Okay, but if their heart rate, for example, is now let's say even just 120, that's a shock index of 1. That's a problem. Okay, so it's not about the blood pressure. It's about MAP is one thing. The other thing is shock index. So if you look at things like sepsis, high negative predictive value with normal shock. So if your shock index is normal in a septic patient, then that's a high negative predictive value in terms of mortality, in terms of for lactate measurement. If you look at cardiovascular disease, not many studies looked at that. PIDs, there's actually a pediatric specific shock index, which is pediatric specific, and higher sensitivity specific compared to other markers and indicators. Not very good in geriatrics for very many reasons, because geriatrics, your blood vessels are all off. They don't constrict or expand as they should be because of atherosclerosis and other diseases, arteriosclerosis and other diseases. There are heart issues. So shock index is not that good in terms of sensitivity and specificity in a geriatric patient. But for everyone else, shock index works wonders. So just know, I did mention there are two things. So these were markers of hypoperfusion, poor perfusion, a MAP and a shock index, not a blood pressure. So you want to know your patient is not perfusing well. You want to figure out what their MAP is. You want to figure out what their shock index is. Now, how do you tell your patient is in shock? Remember, all of this is about end organ dysfunction, okay? So we have your lactate, so elevated serum lactate, more than 2, altered mental status, and decreased urine output, essentially kidneys start shutting down. These are now markers of end organ dysfunction, okay? That are easy to pick up. So patient with altered mental status, decreased urine output, yeah, they may be having fine numbers on the screen, but any of this is a marker of end organ dysfunction. Now, just quick discussion on lactate. I know it's not available in many facilities. So lactate, which is the base of lactic acid, may be elevated in critical illness due to impaired oxygen delivery. Again, it's not just about blood flow. Blood has to have oxygen. So you have type A lactic acidosis, which is about impaired oxygen delivery. So blood may be getting there or not getting there with enough oxygen. So it's a delivery issue. Or impaired utilization. Remember, again, you may deliver all the oxygen to the tissues, but if your cells are not going to use these tissues, this oxygen, then you'll still end up in shock, okay? So if you look at type A, lactic acidosis, so lactate more than 2 is a problem. So type A lactic acidosis can be from decreased oxygen delivery, so things like hypotension, hypovolemia, trauma burns, any reason you've lost volume, severe anemia, okay? Because remember, you need red blood cells to carry oxygen. So if you are severely anemic, you'll end up with impaired oxygen delivery. So type A lactic acidosis. Cardiac arrest, of course, is no blood flow, severe hypoxemia. So hypoxia will give you a type A lactic acidosis. But you can also get a situation where the oxygen is being delivered, but it's not enough, okay? You try running up a mountain or something, your oxygen, it's being delivered, but your body needs more oxygen, but there's actually not that much oxygen available. So stress, pain, fever, hypothermia, shivering, seizures, all this increased oxygen demand. And if you're not giving enough oxygen, then increased lack of breathing, as I was talking about. Then if you're not getting that much, so you may be getting just normal oxygen levels, but your body is demanding more and more, and that's a need to supplement your patient's oxygen. So that's type A oxygen lactic acidosis. Type B is where you have drugs and toxins, which then impair your cells from actually using the oxygen. As you can see, there's things like niacin, strychnine, it's all toxic alcohols, ethanol, methanol. All of these toxic drugs and toxins impair oxygen utilization by our body. There's impaired clearance. This can be impaired clearance of lactate. So liver failure, renal failure, all this mitochondrial dysfunction, which can be again from toxicity, impairs you from utilizing the oxygen. Okay, other things that affect your cells. Sepsis also can cause impaired oxygen utilization by damaging the cells. Malaria, the same, damaging your red blood cells. Alcoholic lactic acidosis is the reason why you can have an increased lactic acid, and then other deficiencies. Okay, so any patient who, if you're in a situation where you're able to measure the lactate, then you need to determine, is it an issue of type A lactic, is it a oxygen delivery issue, or do you have cell issues that is having issues? Thank you, Mohammed. Here you see for the formula, MAP is diastolic blood pressure by, plus a third pulse pressure. There's multiple ways this is formulated. Is it? Yeah, so we're just going to check that one. But yeah, thank you for that. Okay. And then, all right, I saw someone put their hand up. Please put your questions in the chat there. We'll be able to pick them up. Okay. All right. So how do you start telling if your patient is in trouble? Okay. Now, this is when you start knowing your patient is in trouble. Either they're hypoperfusing, okay, MAPs are below 65, shock index is more than 0.7, or they already have started to have features of end organ dysfunction, okay? Elevated serum lactate levels, altered mental status, decreased urine output. So this is when, these are now markers you can use to say, my patient is, if you have end organ dysfunction, then you're already in shock, okay? But if you not have an organ dysfunction, then low MAP, high shock index, then is my patient potentially heading to that end organ dysfunction, heading to that shock. So it's something to definitely. So this is what to note. There's nowhere we're talking about systolic blood pressure. There's nothing we're talking about BP. This is purely markers where you're trying to establish what's their perfusion level. Are they already having end organ dysfunction? Okay. So yeah. So now what? Okay, so you worked it all out. Okay, so you've been able, all right, it's fine. My patient is having shock somewhere. Okay, and I've been able to pick up all this. Okay, so let's look at trying to fix the problem. The first part of it, of course, of anything is trying to identify where the problem is. Okay, is it a heart issue? Is it a blood vessel issue? Your vasculature issue? Is it a volume issue? Okay. Or are the tissues not using the oxygen? So note, based on this, volume is just one component. So if your patient is in shock, your response cannot be, let's give fluids, okay? Note, fluids is just one component of this whole process, okay? You have heart issue, could be a heart issue, vessel issue, volume issue, tissue issue, okay? So we need to figure out where the problem is, okay? So the knee-jerk reaction a lot of healthcare providers have, oh, BP is low, let's give fluids. Okay, that tends to cause actually way more. Who told you it's a volume issue, okay? Or patients, oh, my patient is in shock, let's give fluids. Who said they have a fluid issue, okay? Where is the issue, okay? So giving fluids a very myopic view of a very big problem, okay? Somewhere there's a problem, and you'll be in many situations. Actually, in some situations, giving fluid will cause more problems to your patient, okay? So just so that we're all clear, a normal blood pressure, there's nothing like a normal blood pressure. Your patient has a blood pressure, you need to figure out what's your heart rate and other parameters, things are they vasoconstrict and all that, to determine if they are in shock or not. So do not sit comfortably and say my patient's blood pressure is normal. They are not in shock. That's a lie. Okay. The time that blood pressure drops, you will be yes, let's just say crapping in your pants, because that's normally when all your compensatory mechanisms have been exhausted. Okay. So do not rely on a blood pressure to determine if your patient is in shock or not. Okay. You need to look at their either markers of poor perfusion, which then lead to shock, or markers of endocrine dysfunction, which then your patient is already in shock. Now, once you figured out your patient is headed to shock or is in shock, okay, do not just give fluids. Figure out where the problem is. It's the heart, blood vessels, blood volume, tissue organs. Okay. So let's play a bit here. So let's look at the heart. Okay. So what are you worried about the heart? Okay. The first thing is, do you have enough blood to pump? Okay. Your heart is a pump. If there's no fluid in the pump, it's just pumping air. Okay. So do you have enough blood or volume to pump? Okay. So this is a point where you're actually asking, is there any reason the patient blood volume is low? Are they bleeding, or have they lost fluid or volume from vomiting, diarrhea, excessive urination, like in DKA, for example, or the blood vessels have become just too big, and then the tank, what we call the tank, is expanded, so the volume has dipped, which is a rational dip in volume, because there's no really volume loss. It's just there's no fluid or blood loss. It's just the tank has become bigger. So first part, do we have enough blood to pump? If your answer to this is yes, there's no reason my patient's volume should be deteriorated, then volume is not your problem. Giving fluids is not your problem, okay? So a patient comes in, for example, was healthy this morning, okay? Comes in complaining of, a bit of chest pain and nothing else. So, and his blood pressure is low. Why are you giving him fluids? Is he bleeding? He was fine. He had breakfast. He's having chest pain because something's going on. Okay, so maybe his outflow, number 4 there. He's having a pulmonary embolus, meaning there's an outflow problem. Okay, so he's constricting well. He's not bleeding, so there's no volume need. Okay. So the issue is his heart seems fine for now, assuming he's not having a heart attack. So the heart vessel, the heart as a pump should be fine. And the main issue is having an outflow problem. So the first part is, do you have enough blood? Yes, to pump. Okay. If the answer to that is yes, there's no reason my patient does not have enough blood, move on. Okay. Next, is the heart contracting well enough? Okay. Ideally, you need an echo to kind of have a look at what the heart is doing. But in a patient who's known already to have heart failure, or patient who, for some reason, has been identified to have poor heart activity, then that's a factor. Okay, so if the heart is not contracting well, then you need to do something to make the heart contract better. We're going to discuss that. So which drugs can you give to make the heart contract better? Note, fluids will not make the heart, if the muscle is not functioning well, no amount of fluid, but too much fluids will actually kill that heart, whatever is left of that heart, okay? So is the heart contracting well, okay? The other part of it is the heart rate. Is it too fast or too slow, okay? Too fast, we're talking about abnormally fast. So your SVTs where you're at 150, 180 numbers, and there is no reason why your patient should be having such high heart rates. We had a case this week where a patient actually presented with heart rates of 157, but they had a reason why they should be having a heart rate of about 157. They were dehydrated, they've been vomiting, diarrhea, or something like that, and they were in sepsis. So we gave them the fluid, the heart rate came down, okay? So, but a patient wakes up in the morning, is fine, and maybe had 1 or 2 drinks or something, and then shows up and the heart is 150 and the BP they're already in shock at this particular point, then the issue is not fluid. The issue is the heart rate is too fast. If your heart is beating too fast, there's not enough time for it to fill up with blood during diastole, and that's because it's just so that then reduces your stroke volume, and that's why your patient is going into shock. It's hypoperfusing and they're going into shock. It's because the heart rate is too fast. And this is a common thing you'll see in patients with atrial fibrillation, with a rapid ventricular response, where the heart is just going too fast to allow time to fill up with blood, okay? The other factor of it is, of course, if your heart is going too slow. Okay, remember, perfusion or BP, just using the BP, is heart rate stroke volume, systemic vascular resistance. So if your heart rate has come down, yes, then you're not moving blood as fast as it should be moving around the body. There's a bit of stasis potentially happening. So your body's trying to compensate by vasoconstricting. You're not losing blood anywhere. It's just your heart rate is a bit slow. Okay. And with that factor, then that needs to be, you need to increase your heart rate. So if your heart rate is too fast, you need to bring it down. If your heart rate is too slow, you need to bring it up. Okay. This is, of course, after you've corrected other factors that may be causing this. So, for example, in too fast heart rate, is your patient in having fluid issues? Have they lost fluid or anything like that? Is it an electrolyte problem? Maybe some hyperkalemia or something else. Similar with a slow heart rate, are they just cold? Are they hypoxic? Is it an electrolyte issue? So you need to fix that and then increase the heart rate for brady or slow down the heart rate for tachy. So the other part of it is there a blockage somewhere? Okay. So blockage, mainly we're looking at it from the perspective of, is there a pulmonary embolus? Okay. So the right ventricle is struggling to push blood to make it get into the left ventricle because there's a blockage. Okay. And yeah, so actually what you actually also have is, because there's reduced blood flow to the left ventricle, theoretically you have a volume problem, because now your right ventricle is becoming bigger because it's blocked and it's impinging on the left ventricle. But do not make that mistake of giving fluids, because what's going to happen is you're going to just make that problem bigger. You can imagine if you have a blocked toilet. Okay, it's just simple terms. You have a blocked toilet, and then you go and take a dump again, and a dump again, and a dump again. Yeah, things back up. Okay, next thing, your house is smelling. Okay, because pretty much, and in this situation, your patient's probably gonna crash from too much fluids. Okay, so is there an outflow problem? So do you have enough blood to pump? Is there a heart? Is the heart contracting well enough? So is there enough power in that heart? Is the rate too fast or too slow? Okay. Is there an outflow problem? Okay, or it's actually, so in the heart contracting also, you need to figure out, is it also a problem with the muscle itself? The muscle could be infarcting, things like a heart attack, or the muscle could have failed already. So all of this could contribute to a low, poor perfusion and leading the patient to shock. Okay, there's a questions here. All right, if you raise your hand, what is the best BP range and a MAP in traumatic brain injury? Again, guys, let's forget BP. Okay, let's just BP. MAP is what you're talking about. Okay, so MAP above 65 in any situation. Okay, is what's ideal for your patient. Whatever situation is, keep your MAPs above 65. Okay. Traditionally been taught that shock would present as tachycardia. You'll be shocked for sure. Okay. Your tachycardia is only it's a tachycardia is your normal physiological response to the shock. Okay. So in some patients, for example, look at patients with beta blockers, calcium channel blockers, they're not able to monitor tachycardia. So they still could present with shock without that raise in a heart rate. Okay. Similarly, patients with bad hearts for some reason, then may not necessarily mount that tachycardia that you're looking for. Cold extremities, you clearly not met a sepsis patient. Sepsis patients are very nice warm peripheries. They're not cold and they could be in shock. Similarly, certain heart failure patients have nice warm peripheries. So that is not really. Altered mental status is a marker of end organ dysfunction. Okay, so that is always something too. Patients with an altered mental status is potentially already having end organ dysfunction, and that's definitely a good marker of a patient already in shock. Prolonged cap refill. So cap refill, if you've walked around town in July, if you actually ask people who are not pocketing, the cap refill is a bit low. Okay, because it's a bit cold. So cap refill has it's a good marker. Okay, let's just say cap refill is a good marker, but there are also those caveats in terms of if the ambient temperature is cold, if they're already warmed up. So there are factors that could affect your cap refill time. But yes, cap refill, especially in pediatrics, even in adults, actually, it's a good marker of peripheral perfusion, though. Okay, not necessarily of overall perfusion. Are we throwing this out of the window? No, we are not throwing them out of the window. We are taking them as they should be taken. Okay, so tachycardia, cold extremities, Cold extremities just tell your patient is vasoconstricted. Okay. The patient could be vasoconstricted and not in shock. Maybe it's cold. Maybe they have another reason to be vasoconstricted. Some patients are not vasoconstricted, so they're warm and they're still in shock. Similarly, with tachycardia, as I said, not all patients are motor tachy. Altered mental status is a good indication of shock and end organ dysfunction, which is good. Prolonged capillary fill is good to check, but also has caveats because can easily be affected by ambient temperatures. What makes a heart beat too fast or too slow? There's so many problems, okay? So it could be intrinsic problems of the heart, okay? So for example, you're having a heart attack or toxins to the heart, or your patient is having, what else would make a heart beat too fast or too slow, okay? So it could be toxins, this could be drugs, other toxins that someone has taken. Could be intrinsic issues of the heart, or you have conduction abnormalities, or you have heart conditions that are making it a bit too fast or too slow. Things like hypothermia will cause your heart to be too slow. Hypoxia will make your heart be too slow. If you look at things like electrolyte imbalances, will also cause variations in your heart rate, so can be too fast or too slow. So always look for what else is causing your heart to beat too fast or too slow. But always remember that that's too fast and that too slow is probably contributing to your patient ending up in shock. How do you approach shock in a patient with heart failure? Okay, with hypertensive heart disease, with an AV block and a PRO 47. Clearly, it sounds like you already have the patient next to you. Okay, it's still the basic principles. Where is the problem? Okay, we'll discuss a bit later. Is it, if in a heart failure patient, the first place to start looking for problems is the pump. Okay, how effective is this pumping? Okay, as a first thing. Hypertensive heart disease, nothing to worry about. Okay, that one, it's already damaged the heart. But the question is, how good is this pump beating? Okay, and that's normally the first place to start off. So if your patient has an AV block, then the next thing you're looking at, what's their heart rate? So it can be the pump is not pumping hard enough because it's already weak, so it needs something to make it pump harder. But also your rate of the pump may be too slow. Okay, so if an AV block, then your heart is not pumping. So your patient has a pump problem from the perspective of it's not contracting hard enough, it's not beating fast enough. Okay, so that's a patient who you will now need to figure out, and we'll discuss this, how to make it beat harder, how to make it beat faster. Does lactic acid level predict mortality? Lactate has multiple issues. Okay, there's also a clearance issue, but lactates above 2 are a good indicator of end organ dysfunction. In terms of what number, actually, I'm not sure what number would say predicts mortality. But one thing I can tell you, lactate clearance, which is how quickly the lactate dissolves, does not necessarily, is not a good indicator of your resuscitation efforts. There's sometimes looking into that. All right. We are used to correcting hypotension with fluids. Yes, stop. Hypotension. So that's the other thing. English, there's hypotension and hypovolemia. Okay? Hypovolemia is fixed with fluids. Hypotension is not fixed with fluids. Tension, pressure, volume. Okay, so hypovolemia can lead to hypotension. Okay, but hypotension is not equals to hypovolemia. So you need to figure out, does my patient have a volume issue? Okay, so it's not a good approach to correcting hypotension with fluids. It's a good approach to correct hypovolemia with fluids, not hypotension. Okay, so you need to figure out, is my patient hypotensive because of fluids, in which case they're hypovolemic, then fluids works. But is my patient could also be hypotensive because pump is not working, pump is blocked. There are many reasons why they could be hypotensive. All right. Now, tachycardia in compensatory phase. Yes, that happens a lot. And that's one of the things we're discussing earlier. Good. I think I've answered the questions so far. All right. So we actually just still at the heart issue. All right. Let's look at the next part. Okay. So it could be a heart issue. Now, it could also be a vessel issue, okay? So your heart is beating perfectly fine, okay? But what is your blood vessels doing, okay? So your pipes could either be blocked, okay? Big problem, okay? Pulmonary embolas, heart attacks, your pipes are blocked, okay? Though heart attack is more about just specifically for the heart, which then will lead a pump issue. But pipes blocked when you're looking at pulmonary embolas, okay? But, which is also the thing is, think about a patient having tension pneumothorax, okay? The pressures within the thoracic cavity will collapse your inferior vena cava, for example, and will also constrict on your aortic outflow. Okay, so your pipes can be blocked because they're blocked from inside, or they can be blocked because they're blocked from outside. Okay, so I know the first one we always say pipe blocked, we always think about pipe being blocked from the inside, which is a pulmonary embolus. Okay, but the pipe could also be blocked from the outside. So something constricting your blood vessels, especially your major blood vessels leaving the heart, could be a big issue. Okay, and could lead to blockage. So patients, for example, with superior vena cava syndrome, so they're just blockage of the vessel by some cancer of some sort. Okay, so do not think about pipe blocking just from the inside. Pipe could easily be blocked from tension pneumothorax. Okay, things like cardiac tamponade mainly will constrict the heart, so it will affect the functionality of the heart. Okay, are the pipes leaking? Okay, this happens a lot. If you're in a car crash and you start bleeding, or you're bleeding from your stomach, or someone has decided to stab you somewhere, the pipe is leaking because you're bleeding. Okay, so leaking pipes first thing you need to close that tap. Okay, no amount of fluid is going to replace blood that is being lost. Okay, if it's going, it's going. So first thing, close the tap. Okay, but you could also have pipes leaking because of vasodilation and things like sepsis, which essentially impair the endothelium and cause all your blood vessels start leaking out fluid into your interstitial tissues, into your interstitium. Okay, so pipes could be leaking because they're broken. Okay, in a patient who's having bleeding for some reason, whatever reason that is. But also pipes could be leaking because they have just become porous. Okay, your bacteria has just created too many holes in them, so you're leaking and ending up in edema and such things. Okay, so that's pipe leaking. Now, the other part of it about pipes is, have the pipes changed the size? Okay, now, if your pipes were just normal, okay, and blood was flowing perfectly well, that's fine. And then for some reason, your pipes become now bigger. Okay, so all of a sudden, the same amount of blood which was flowing within small pipes is now flowing within a big pipe. Okay, so that becomes a problem, because then the volume has dropped. Your blood volume drops. It's a relative drop because you're not bleeding, you're not losing blood anywhere. It's just that now blood is swimming in a bigger pipe. Okay, and that becomes a problem because then it's not enough pressure for it to get into your tissues. Okay, so from a pipe's perspective, the question is, are my pipes blocked? Are my pipes leaking, or have my pipes changed the size? Okay, so if they're blocked, I need to unblock them. That's simple. Okay, so thrombolize your pulmonary embolus, or decompress your tension pneumothorax, for example. If they're leaking, then you need to stop the bleeding fast. If it's bleeding, vasoconstriction helps in terms of causing in a patient who is leaking because of sepsis. So it's not leaking because there's a traumatic issue. It's leaking because of sepsis, then you need to cause a bit of vasoconstriction, because also their pipes are also quite big in anaphylaxis, so you need to cause vasoconstriction. So there's now some question. An non-traumatic patient with no other clear history presents with a BP of 80/50. What's the approach? Exactly where we started from. Is it a pump issue? Okay, so is their heart beating effectively? What's their heart rate? I'd like to know what their patient's heart rate in this particular case is. Okay, so is their heart beating effectively? Is their heart rate okay? Is there potential blockage of the outflow tract? So maybe you're getting an ECG to see any features of pulmonary embolus. If you're in a place to get a CTPA, get a CPA. But the other part of it is it a pipe issue? Okay, pipes are blocked, pipes are leaking, pipes have changed size. Then is it what's this other part of it called? So it's pumps, pipes. So it could also be the volume. They're bleeding from somewhere. They're losing volume. They're either bleeding or losing volume from a tissue, from a dehydration or something, some reason why they're losing volume. And the other part of it that people don't always factor in, which is what I'll talk about as we get down, is the car itself. Maybe the car has a problem. Okay, I'll discuss that as we go down the discussion. Pipes can change size because of clots. Yep. Actually, pipes block because of clots. The size part is more about vasoconstriction and vasodilation, but they definitely can be blocked by clots. Okay. All right, good. So let's continue. Now, this is for patients whose pipes are large. Okay. So we've discussed heart tissue, we've discussed pipe issue. Okay. Now, the good thing is you have some drugs to play with, okay, that can help you improve pump function and cause also vasoconstriction. But also in certain situations, for example, in a heart failure patient, then you may want to cause, because in a patient with hypertensive heart disease, sclerosed blood vessels, you may actually want to cause a bit of vasodilation because your heart is pumping against a high resistance, okay? In that situation, you probably want to vasodilate them a bit, but that's a different discussion. The simple discussion here is, do I want to cause vasoconstriction? Because my patient's anaphylaxis, sepsis is massively vasodilated, then I'm looking for a vasoconstrictor. Here I'm looking for something that will cause more vasoconstriction. That's your norepinephrine, okay, will definitely cause more vasoconstriction. And in the same, as you can see, to increase my systemic vascular resistance, it's definitely going to increase my heart rate. So that also increases my cardiac output. But caveat, before you start vasoconstricting patients and before you start pumping, okay, increasing contractility, please make sure you have blood to flow, volume to flow, okay? So in certain situations, you actually can start both simultaneously because you can start some fluid replacement and you start your inotropic or vasoconstrictive parts. But this is where you have established your patient has a volume issue, a pipe issue, and a pump issue, okay? So you need to fix all three at the same time, okay? So you could easily start your fluid resuscitation, and in a lot of studies are showing that you can start your inotrope and vasopressor earlier than waiting for you first to fill the fluid, then starts the pressors following, okay? So they don't need to be one after the other, okay? You could easily start your fluids and then start, but this is a patient who you think there's a volume issue. Now, for drugs, so the drugs that we have available that are used for inotropy, this is why you have a purely heart problem. Your vessels are fine, they're working as they should be, you've not lost volume anywhere, but your heart muscle is having a problem, okay? In that situation, you're looking for a drug like dobutamine. That's what we actually have available. That is more doesn't fasting, of course, will increase the cardiac output by stimulating your beta 1 receptors, but also does cause a bit of vasodilation, which in a patient, remember, can you imagine if you have a weak heart and you still have hypertensive heart disease, you have sclerosed blood vessels, so your vessels are all narrow. And you have your narrow vessels and you have this weak heart trying to pump against these narrow vessels. In that situation, then your patient could easily be in shock because your vessels are too tight, okay? And your heart is a bit too weak, okay? So to fix that, you need to relax your vessels a bit and give your heart a bit of stimulus, okay? So that's where a drug like dobutamine comes in place, where you're trying to cause a bit of increased inotropy, increased pumping of the heart. So the two drugs that really focus on this discussion is norepinephrine, okay? Though you could use, let me just hide this because I can't see anything. There we go, okay? So norepinephrine if you have access to it, but epinephrine is also quite a good drug, which kind of does both, okay? So it will cause vasoconstriction. So be careful about causing vasoconstriction in a patient with a poor heart, because essentially, you are flogging a horse to die, because you can imagine if your heart is already weak and then you're causing vasoconstriction, so your heart is now struggling even harder, it will fail. Okay. So, but in a person who there is no problem in the heart and you just want your vessels are a bit too big and you want a bit of vasoconstriction, then epinephrine is a good drug. Epinephrine also has inotropic effect, which is quite good. And that's why a lot of times we'll end up using epinephrine for your ACLS, your anaphylaxis. So anaphylaxis is good because you're causing that vasoconstriction. You really want that vasoconstriction. And then septic shock patient, normally as a second line drug, remember, sepsis, majority of the time will cause vasodilation, but sepsis also affects tissues. So it can damage the myocardium and make the myocardium weak. So in that situation, you probably want something that can vasoconstrict a bit and also cause a bit of inotropy. In such a situation, then, epinephrine will do much because it doesn't have that kick you require for your inotropy, but your epinephrine will do, okay? Dobutamine is where you're looking. Dobutamine is good for cardiac patients, okay? So patients whose sole problem is the heart, okay? The heart is only one that's a problem, is a post-MI heart failure, and you need the heart to have a bit of kick, then that's a drug. So no one should be using dobutamine just causes too many cardiac arrhythmias. The others are, some are not even available here, but others preferentially you should be using in consultation with the experts, okay? But for you working the AD, norepi, epi, and dobutamine. So noradrenaline, I know we call them adrenaline, noradrenaline, adrenaline, and dobutamine are your best friend in the emergency department. Rarely will you ever be using any of these other drugs on this. All right. So I did see some questions. In MAP, is there any difference when the machine calculates and when the manual calculated? Right. No, unless you really want to draw to split hairs, the machine normally should be fine. I tried to calculate manually, but found out it doesn't correlate with the machine one. It depends how the machine is calculating on machine and the calibration sometimes. So always counter check that. In hypovolemic shock, but remember again, just not rely on just one marker. Remember, there are markers of poor perfusion and there are markers of end organ dysfunction. So always check both. Okay. In hypovolemic shock secondary to massive blood loss, in our setup where blood acquisition is a difficult process, what's the best practice? First thing, close the tap, okay? Stop the bleeding. Try to figure, just put a finger, whatever the bleeding is, that needs to be stopped. Okay, that's the first part. Second part, tranexamic acid. Okay, 1 gram tranexamic acid start, 1 gram over 8 hours infusion is your next best friend. Okay. The third best thing is you have to find blood. You can normal saline is not a good carrier of oxygen and all the other nutrients. You need blood, okay? But many times the first thing is try and stop that bleeding, okay? Stop the bleeding. If the patient needs to go to theater, take them to theater to just stop the bleeding, okay? That's called damage surgery, I think that's the term, or damage resuscitation, where you just go to theater to stop the bleeding and then you resuscitate your patient. Okay. But the longer your patient, so that's the thing always you need to remember, the longer your patient is bleeding, the more blood which you don't have, you will need. So stopping the bleeding is a good idea start. Okay. In volume resuscitation, is dilutional anemia concerned, or how much fluid is safe? The thing is, there's a lot of discussion about dilutional anemia, which is theory more than practice. Okay. If you have 5, let's just work with simple numbers. If you have 5 hemoglobins, 5 of them, okay, that are moving oxygen in your whole body, okay, whether you have that 5 hemoglobins in 5 liters of blood or 5 hemoglobins in 1 liter of blood, they are still 5, okay? So the 5 are still the ones that will carry oxygen, whether they're swimming in an ocean or they're swimming in a fish pond, they're still 5, okay? So the issue of dilutional anemia being a factor is not really a factor, but because your fluid is not what's carrying, it's your 5 HBs that are carrying the oxygen. That's what you need to factor in. Now, the other part of it you need to think about is you should not be giving too much fluid. If your patient needs blood, that should be replaced with blood, okay? They should not be fluid overloading your patient. And we discussed just now how to look into fluid resuscitation and what needs to, how you can figure out whether your patient needs fluid or not. Okay. All right. So the question on fluid safe will be answered shortly. Shock due to HHS in DM with decompensated heart failure. Yes. Let me just tell you that patient is in trouble. They have an 85. My first mortality was a patient in DKA and heart failure. The mortality is like 85%. You have a problem. But in simple terms, you need to have to help the heart a bit. Okay. So still pipe pump volume. Okay. So you need to remember in heart failure, the main issue is the pump is not working. So the first thing you want the pump to work so that you stop backing up fluid and ending up in all the failure factors. So pump up the blood a bit and then now slowly start rehydrating or not rehydrating, actually, just replacing volume in your patient. But do not replace volume if your pump is not working, because then all you're causing is more problems for your pump. So pump fast, then start. And then also you can, yes, so that would mainly, if your pump is working, to start moving fluids around, to start moving, then you can actually now give the fluids after that. Is it a must have a central line using pressors? Answer coming up in the next slide. What about use of calcium? I'm not sure about that. Okay. You give calcium if you're correcting hyperkalemia, or give calcium if you're correcting hypocalcemia. All right. Dobutamine is likely to cause ischemia. Okay. Should we only be using norepinephrine or epinephrine? No. Dobutamine in a patient who has a purely heart issue, is your heart failure patient, fantastic drug, okay? Doesn't really cause ischemia. What could, yeah, that causes ischemia. No. So no, you can use dobutamine in a patient who is in heart failure and they need their heart to beat a bit. So that's where dobutamine comes in. A heart failure patient whose heart is not beating as effective. They have volume, which is fine. The vessels seem to be fine, but you need a bit of kick on the heart, then dobutamine comes in. Adrenaline and norepi, the problem with those two in a patient who has a purely pump problem is they also cause vasoconstriction. So yes, they'll improve the beating of the heart, but they'll also vasoconstrict, which then will cause the heart to work harder and fail faster, I guess. All right, digoxin in cardiac failure, me see cardiologist. Speak to cardiologist about that. I haven't seen anyone on digoxin for a while, and it's not a drug we'll use in the ED for heart failure. So yeah, check with the cardiologist on that one. Damage control surgery, yes, that's what I was looking for. Thank you very much, Johnson. Yes, so damage control surgery is where they just go in, stop the bleeding, because the more you keep bleeding, the more blood you will need, which you actually don't have from the first place. So stop the bleeding, give tranexamic acid, look for blood, okay? Don't just start pumping them aimlessly with fluids. That's not going to end up well for you for sure. Yes, all right. I think I've done all the questions for now. All right, so next, okay, so can we give inotropes or vasopressors through a peripheral line? The answer is yes. Multiple studies have looked at this, and yes, it is perfectly safe for you to give your adrenaline infusions, noradrenaline infusions, dobutamine infusions through a peripheral line. Okay, so let's establish that it's safe. But these are some of the rules that you have to follow when you're doing this to make sure you do not cause issues on your patient's arm. Okay, so it's 100% safe if you follow these rules. If you don't follow these rules, then there's a chance you'll actually harm your patient. Okay, so number one, you want to use the antecubital fossa or more proximal. You need a big vein. Okay, do not start inotropes on a yellow line or a blue line. You will definitely cause gangrene on your patient. Okay, so the bigger the line you can get, pink, green, gray, orange, the fatter the line, the better. Okay, and you're using an antecubital fossa. Yes, some peripheral lines, but probably just antecubital fossa, and get in a big gauge cannula. Do not start pediatric lines in do not start pediatric lines and start inotropes on that. It's gonna extravasate. If you have ultra long catheters, there are some catheters that are available that are long. Like as you can see, this patient has pretty much actually just they call the long lines or PICC lines. I don't know. I see who has a name for them. So the longer the line, the better. Okay, and then can be used peripherally. Maximum 4 hours. Maximum 4 hours. Okay, so starting peripheral pressors is a stopgap measure as you set up your central line. It is not a replacement for your central line, okay? The issue is we've seen a lot of patients crash because someone is trying to fix a central line while the BPs are just poof. Start your peripheral pressors, get your central line up, then you will switch your pressors to your central line, okay? Do not wait for that central line to start your pressors because by the time you're getting that central line put in, your patient may be dead, okay? And central lines don't really work well when you're dead, okay? So you can start peripheral pressors as you then set up a central line. So starting peripheral pressors is not a replacement for a central line. It's a temporary measure that should not exceed 2 to 4 hours, 4 hours max, as you then set up an IV line. A central line, okay? Dilute the concentration as much as possible. So you do not want to be giving neat drugs. So make sure you are running, you can even just put 1 milligram of norepi in a liter of fluid. So just dilute it as much as possible to reduce the concentration of the drug going through the line. Have an observation protocol. So someone should be keeping up in that to make sure that line is still flowing perfectly well. It's not going into the tissues. And then should it go into the tissue, you should have a protocol about what to do, okay? And you can read up on this online. But yes, you can definitely give pressors through a peripheral line. You just have to follow these rules. If you follow these rules, you're perfectly fine. You don't follow these rules, shauri yako, okay? You will end up in trouble and that will be your fault, okay? As I said, peripheral pressors are as you establish a central line. They are not a replacement for a central line. All right, so good. So we discussed about giving drugs to help the heart to constrict the blood vessels. Let's look at also fixing them, okay? What if it's a volume issue, okay? What if you have a blood volume issue, okay? This is one which everyone is common about. You're either bleeding too much, okay? So the question is, have we lost blood or volume? So volume, I mean fluids, for example, diarrhea, vomiting, and any other reason why you could be losing fluid. So if you've lost blood, we need to replace blood. If you've lost volume, we need to replace volume. Now, or have the pipes changed? So is it a relative blood volume loss because the pipes have changed size? So you're not bleeding, you're not leaking fluids, it's just the pipes have changed size, okay? So in this situation, you just need to resize the vessel, okay? You do not need to start giving volume. If it's a pipes have only changed size, then resize the vessel. Do not start pumping fluids, okay? Do not start filling your big pipes with a lot of water because they're eventually going to come down and then your patient will be frothing all over the place because they're not in pulmonary edema, okay? If it's purely a pipe, you should fix the pipe, okay? But if they've lost volume in terms of actually blood volume loss or fluid volume loss, then you replace the blood and replace the volume. So how do you determine if your patient needs fluids? This is a simple bedside test that has sensitivity of 79%, specificity of 85%, okay? Essentially, put your patient up 45 degrees, check their blood pressure, okay? Drop the head down, put the legs up 45 degrees, and within a minute or two, check their blood pressure again, okay? So a change in pulse pressure, so you change in pulse pressure, that's the systolic blood pressure minus the systolic blood pressure, more than 9% is indicative of a patient who will respond to fluids, okay? That patient needs volume. Of course, do not start doing this in a patient who is bleeding from trauma. Definitely, you can see the blood loss, okay? Or they've come in diarrhea, vomiting. But in a patient who you're not sure if you need to give them fluid, because you're not sure about this loss business. Are they fluid adequate, not fluid adequate? I'm over sure, do a passive leg raise, okay? Essentially, 45 degrees, check the BP, systolic minus diastolic, and then check the pulse pressure, drop them, and then do the BP check again within a minute or two. Check, and then if there's a change in pulse pressure by more than 9%, your patient needs fluid. Okay. Passive leg raise should be done. To use this anytime you're not sure that you need to give fluids, do this. Okay. This will help you then determine if there's no change in pulse pressure, then you don't need fluids. It's either a pump issue, pipe issue, something like that. Okay. So, what fluid? Okay. All right. So if you look at this, your plasma is here at the center. Okay. That's your plasma level. So osmolarity is that, sodium is that, chloride is that, potassium is that. Okay. Anything that is hypotonic, okay, as you can see, this is the tonicity of dextrose. So you should never be giving anyone with anything containing dextrose or half saline or anything as a resuscitation fluid. No. Okay, that will just end up in tissues, and I'll show you where that goes. Okay, Ringer's lactate is good. Plasma light, we don't have that here. Saline is good, but it's a bit more on the almost tending towards the hypertonicity side. I like Ringer's lactate personally. Works perfectly well, less sodium issues, and also the pH. If you're looking at it from a pH perspective, then patients who saline is a bit more acidic than Ringer's lactate. But yeah, so this Ringer's lactate, plasma light, and saline are good fluids to be giving. This, as you can see, is tending towards being more, the osmolarity is quite high on that one. This is dextrose with bicarb. So stick to the isotonic fluids, okay? Avoid the hypertonic or hypotonic fluids. No, do not ever give anyone dextrose as a resuscitation fluid. Yeah. So, because let me show you where the blood goes. Okay, so remember, we still have our car here. So essentially, this is where, so you want, this is your plasma, okay? That's intracellular fluid, extracellular fluid, okay? If you're giving dextrose, bulk of the fluid will end up in your intra. This is so it's a little of each. Bulk of your fluid, as you can see, end up is in your intracellular, intracellular fluid, yes, okay? If you're giving half saline, bulk of it there. Normal saline, Ringer's lactate, none of it is ending up there because you want blood to remain within the blood vessels. So you want fluid to remain within the blood vessels. So you can see if you give a patient blood all of it remains 300 mLs of packed red blood cells, all of it remains in the plasma. Now, interesting enough, if you give Ringer's lactates or normal saline, if you note, only a third of it remains intravascular. So when you give a patient a liter of fluid, it's not a liter that remains in the plasma. It's only a third of that, which is 250 mLs that remains in the plasma. And a good number of times that's probably adequate enough, okay? So if you're giving a lot of fluid and the fluid is just ending up, and that's why sometimes also important to cause the vasoconstriction early, so you don't have fluid piling up within your blood vessel, and also start reducing the amount of fluid leakage into your tissues, again, through the vasoconstriction perspective of it, because you don't want fluid ending up out here, okay? As you can see here, fluid ending up. This is where your pulmonary edema, when your patient starts frothing, that's where it's coming from. So you need to avoid a lot of fluid ending up out of there blood vessels, into your interstitium or into your the intercellular fluid, okay? Especially in your interstitium, that's when you start frothing a lot, okay? So keep your blood, so as you can see, only a third of the fluid you give ends up in your blood vessel. The rest of it goes outside. Vasopressors would cause gangrene on a peripheral line. If you do not follow the guidelines I've said, then the vasopressor would get into your tissues, cause vasoconstriction, close off your blood supply, you end up in gangrene, okay? We can't see the chat questions disabled. Sorry, I'm just answering them live, so I'm just reading them out. Don't worry about that. All right. Okay, good. All right, so back to where we were. Now, a tissue problem, okay? So we've discussed a lot of this high floating. Yes, we've discussed a heart problem, discussed a blood vessel problem, discussed a blood volume problem, but many people trying to ignore, is it a tissue problem, okay? So the tissue problem comes in is the patient just not getting enough oxygen, okay? Are the tissues not getting oxygen? So that's a tissue problem, okay? Or have the tissues been poisoned, okay? Cyanide, carbon monoxide. So they're getting oxygen, but they're not able to use that oxygen. So your tissues, you're having end-organ dysfunction, not because there's no good blood flow, but it's because the blood getting to it doesn't have oxygen, or the oxygen is breaking into it and your patient is not able to consume the oxygen properly. This is commonly seen in patients with carbon monoxide poisoning, cyanide poisoning, but also sepsis patients. Sepsis patients could be easily having good blood flow, but their tissues, especially myocardium, gets the infection then affects the myocardial activity. Your tissue is not able to consume the oxygen appropriately. So you're having features of heart failure, yet they're just septic. The heart is fine, just not consuming the oxygen appropriately, okay? So always factor that in, that it also be a tissue problem. You need to give them oxygen, you need to correct the toxicity that's going on and fix the toxicity to be able to then restore their normal cellular function. Quick poll, so we'll keep this to 30-second polls. Patients with sepsis, where is the problem? Is it the pump, the pipes, the volume, the car, or all of them? In a patient with sepsis, where is the problem? So let's see what people thought. A good number thought it was the pipes. Interesting, 42%. Number 2 thought all of them. Some guys then thought the car was a problem. All right, so let's see what could be the problem, okay? In sepsis is a very fantastic disease. Well, not fantastic, but definitely cause a problem. The first problem is, of course, the pipes, okay? Sepsis causes, because of the endotoxins, causes massive vasodilation. Now, because of the massive dilation, and then also causes, so it causes, not only causes dilation of the blood vessel, but also causes leakage of the blood vessel because the endotoxins damage endothelium. So you have a volume problem. You have a volume problem, which is a real problem because of the leakage, but you also have a volume problem because of a relative volume loss from the expansion of the blood vessels. You have a heart problem. Remember, sepsis causes toxicity of your tissues, okay? Your myocardium is one of the tissues that will definitely be affected, and you actually can get myocardial, your myocardium will not, in some instances, myocardium will not work effectively because it's of the infection, okay? The endotoxins inhibit the functioning of the myocardium, okay? And of course, you have a car problem, which is your tissues and your organs, because they're also having the same endotoxins. So remember, your heart is also an organ, okay? And the toxicity caused by the sepsis does impair oxygen utilization by your tissues, leading to you having end organ dysfunction. And always remember, the heart is an end organ. So in your patient here, you probably will need a bit of vasopressor. You need fluids at a certain point to replace the volume loss. You will need a bit of vasoconstriction, so you need a bit of pressors. But in some instances, your pressors are not getting you where you want to get to, then you may need to give them a bit of pump issues. Okay, so you may need to give a bit of inotropes, because if you have given fluids and you're giving your inotropes and you've done your passive leg raise and you're like, okay, no more fluids, let's give vasopressors. Your vasopressors are location where you need to go to, then your heart is actually having a problem, okay? So you need to start pumping your heart, okay? And if there's a need, please do not give oxygen if your patient starts are not hypoxic, less than 94, because then too much oxygen also then will damage things much further. All right, good. All right, so let's look at the next question. Where is the problem in attention pneumothorax? So correct, majority pumps and pipes. Okay, interesting. All right, pipes and the car. Okay, I don't know why you have against a car. Volume and pipes, pump and the car. All right, so let's look at the problem. So the ones who said pipes and pump is a right. Okay, so in attention pneumothorax patient, the first thing is, again, as I mentioned, your heart there's so much pressure from outside the heart, so it's constricting on your blood vessel. So unless you're bleeding, then you don't have a volume problem, okay? It's just air inside the chest that's causing compression of your heart, okay? So your blood vessels your IVC is being compressed from outside, your aorta is being compressed from outside, so you have a vessel problem, okay? The other part of which is you have a heart problem, okay? Because the heart cannot expand to fill up with blood enough for it to pump. Remember, your stroke volume is being compromised because your heart cannot expand as it should be, and it's permanently being squished by the pressure within the chest. All right, so good. All right, so so it's a pump and a vessel problem. And here, decompressing the pneumothorax will automatically fix everything. Nothing to worry about that. All right, anaphylaxis. Where do you think the problem is in anaphylaxis? So the correct answer is, let's see, majority thought it's a volume issue and a pipes issue. Yes, and that's the correct answer. Okay, so why is the issue? Because you have anaphylaxis, you have massive vasodilation, that means your vessels are all big. But also, the vessels are leaky. So you have a volume issue. So it's a relative volume issue from vasodilation, but also an actual volume issue because there is leakiness of the vessels. All right, so this is what you all thought shock is. And I know you all went through that whole discussion, distributive, cardiogenic, obstructive, and hypovolemic. But a discussion a bit deeper than that from what we've gone through today. Let's see. Yeah, so I hope you've understood. So in a distributive shock, for example, in your septic shock patients, yes, it's a pump issue, it's a vessel issue, it's a volume issue, and cardiogenic is mostly a pump issue. Obstructive, it's a pump issue, it's a vessel issue, for example. In hypovolemic, it's mainly a volume issue. All right. So, but always remember, it's not just about the BP, it's evidence of poor perfusion, evidence of end organ dysfunction. And that was shock it's not a blood pressure issue. And let's manage shock effectively. And please do not give everyone too much fluids.